Thank you, Anita, for showing us the data we have to base our decisions on. First, conflicts of interest. I get lecture fees and research grants from ResMed and Philips Respironics. A group of researchers and clinicians wrote a task force paper for the ERS and made an effort to summarize the evidence in statements to advise treatment of central sleep apnea. So in the following, I will show you different cases, and my personal opinions usually are similar or the same, like in this task force paper. I will begin with a patient whom we cannot recommend anymore to use ASV. It was a 75-year-old patient with reduced ejection fraction and severe central sleep apnea. So the attitude of the patient maybe is reflected by the fact that he refused implantation of an implanted defibrillator. His clinical appearance was relatively typical. He made a drawing for us and wrote a poem about his stay in the sleep lab. And the short translation is that he had only mild sleep disordered breathing related symptoms. He didn't really like the mask he had to wear, and finally he accepted the mask to please his wife and the doctors. You know this date. This was 2 years ago in May, the release of the field safety notice from ResMed after the Servo-HF trial. It was here in the device readout of this patient. It took for us some days to collect all our ASV patients, and here we contacted the patient and advised him to stop using the ASV device and ask him to come to our sleep clinic. And we see before he came to our sleep clinic, after a few days, he started again using it. So this was one of 2 patients who continued on ASV, and although he had no major symptoms in the beginning, he got used to the device, felt that he slept better, and after getting all information, he decided to continue. But this is an hour 11 exemption. I want to make one point to the sub-analysis of the Servo-HF trial. There is this paper from Eulenburg, sub-analysis of the Servo-HF study, that with low ejection fraction below 30, the risk of sudden cardiac death is the highest. And it's important to note that this doesn't mean that we are safe between 30 and 45. I think it just gives us more safety when we have, for example, a patient with ejection fraction 46. Everybody knows that determination of ejection fraction is not a sharp measure, and so we can confidently say that we can treat patients with ejection fraction more than 45. And here, the sub-analysis with the manually scored periodic breathing indicates when there is less periodic breathing, the ASV group had even better outcomes. So I think it's also very important to differentiate between central and obstructive apnea. I suspect that this periodic breathing is an indicator for a higher percentage of obstructive sleep apnea, because it was not a computer scoring, it was subjective by the scorer. We did a similar analysis like Dr. Brill from Bern. We saw the analysis. We analyzed all patients who came back to our sleep lab after the field safety notice, and we found that most of our ASV patients had severe sleep apnea. Many patients had pure central sleep apnea diagnosis, but there's a serious number of patients who had either pure OSA in the first PSG or a combination of obstructive sleep apnea and central sleep apnea. And finally, the indication for this patient was in the OSA case, CPAP emergent CSA, or in the combination case, CPAP persistent HA. And when we have the criteria, AHI on CPAP is still above 15, predominant CSA for at least one night on CPAP, we usually go to ASV. Similar to the analysis we have seen before, in both the cardiology lab and in the respirology lab, the proportion of patients in the risk group is relatively low, a little bit higher in the cardiology sleep lab. We were searching for these patients for our studies systematically for many years, so we see more of these patients. But in a normal sleep lab with a normal referral environment, it's really a very small proportion, because these all are ASV patients, not all positive airway pressure patients. So this is less than 2% or 1% of the sleep labs population. This is a more detailed analysis about the indications of these ASV patients. Why did they get ASV? And actually found that the majority, 67% of ASV patients, had predominant obstructive sleep apnea in the diagnostic PSG. And the majority, 79% of patients with CSA and OSA had heart failure. So the likelihood to develop CSA on CPAP is much higher when there is heart failure. And the drug-induced, opioid-induced central sleep apnea is a rare condition in our sleep labs.